Hi, my name is Tom Nelson. I'm a professor of radiology at the University of California in San Diego, and today I'd like to discuss CT dose control and optimization techniques. New CT technology has facilitated more rapid, sophisticated scanning, but however there is the potential for overexposure with such capability. The number of CT examinations has more than doubled in the past 5 years, now currently greater than 60 million examinations per year, and an additional 4 to 5 million examinations performed in children. As you can see in the lower left-hand pie chart in this image, in 1980, natural background radiation was the predominant radiation we were exposed to, with medical being less than 20%. However, in the 2000s, because of the advance of technology, medical exposures to the population now approach 50% of their annual exposure, and of that, almost half of the medical exposures are due to CT. The radiation dose from a single CT scan is relatively low. However, there is a slight increased risk for developing cancer from stochastic or non-deterministic effects related to the induction of carcinogenesis. In addition, there may be changes to the patient's genes that occur over the course of their lifetime, and those genetic effects can be passed on to offspring. Deterministic effects also can occur at certain dose threshold levels, and these are the most directly visible over short periods of time. Radiation effects are cumulative, and thus the risk increases with each subsequent exposure. Studies do suggest that CT scan doses are higher than necessary, and thus we need to use technology advancements to reduce radiation dose. Defining the risk of a CT dose is complex for several reasons. First, risk assessment involves populations of patients. There also is a risk versus benefit aspect for each CT study. And finally, there's an intrinsic risk for developing that disease even without radiation. As we can see in the lower graph, the lifetime risk of cancer induction for persons exposed to a relatively high level of 100 milligray decreases with increasing age. However, it is more significant for children and for females, particularly at the younger years. Radiation dose is measured with a quantity of the absorbed dose, which is the amount of energy absorbed per unit mass, and uses the unit of gray, 1 gray being equivalent to 1 joule per kilogram. In addition, we also use an effective dose, which is reported in units of sievert, and that is the sum of the critical organ absorbed dose multiplied by an organ-specific weighting factor, so that the dose in sieverts is equal to the dose in gray multiplied by a weighting factor. The table on the bottom shows the effective dose for a number of radiological procedures, and we can see that CT is significantly higher on the per capita dose than any of the other radiographic, fluorographic, or interventional procedures. The good news, however, is that since the 1980s, the CT-DI vol for a routine abdominal CT has steadily decreased from greater than 45 milligray to on the order of 15 milligray in the 2000s, largely due to technology improvement. Nonetheless, we need to pay close attention to the amount of radiation that we deliver. As can be seen in this slide, in the upper right-hand image, a person has significant hair loss as a result of overexposure from a head CT perfusion study. The lower image is from a fluoroscopic interventional procedure. But you can see from this table that most threshold doses are in the range of several thousand milligray compared to a typical CT scan of being 1 to 5 milligray. Thus, to reach levels where there's a observable deterministic effect requires a significant overexposure. We report CT dose using the volume computed tomography dose index, or CT-DI vol, which is reported in milligray. This parameter is measured for the dose delivered under standard conditions using either a 16 or 32 centimeter acrylic phantom. The console CT-DI vol is based on manufacturer factory measurements, but it has been verified by a medical physicist. It's very useful to track dose across patients, protocols, and scanners. In addition, the American College of Radiology Dose Index Registry allows CT-DI vol comparisons across institutions. The CT-DI vol provides an estimate of patient dose. However, the accuracy of that estimate depends on the relative size of the patient and the phantom. As we can see in the image at the bottom of the slide, for 3 different phantoms, the CT-DI vol was measured. On the largest, it was 18, then 37, and then 47 for the smallest. Depending on whether it was being reported for a 16 or 32 centimeter volume, it significantly over or underestimates the actual dose to the patient, and thus it's important to match the dose numbers to the actual size of the patient. We also report the dose length product, which is calculated by the scanner, and it is the average CTDI vol over the distance of the scan multiplied by the scan volume. It has units of DLP, has units of milligray centimeters. We can compute the effective dose, as I mentioned. In the case of CT, it's the dose length product multiplied by a conversion factor that takes into account the radiosensitivity of the tissues. As you can see in this table, those radiosensitivities vary with the organ and the age of the individual at the time of scanning. Finally, diagnostic reference levels have been defined by various countries and regulatory agencies for CT levels in adults and in children. In the United States, the American College of Radiology has specified a diagnostic reference level for head CT and abdominal CT, and these are the parameters that are used as a part of the accreditation process. Those parameters that affect CT dose include beam energy, X-ray fluence, detector configuration, pitch, exposure area, and the number of phases. Beam energy, or tube potential, determines the energy of the resulting X-rays. The larger it is, the more penetrating they are. The dose is approximately proportional to the square of the percentage change in tube potential. Decreased kVp values can reduce patient dose and improve tissue contrast, as can be seen in the lower images on this slide. At 100 kV, we've reduced the dose by approximately 20% and improved the soft tissue contrast. X-ray fluence is determined by the tube current. It's the number of electrons produced, which is directly related to the number of X-rays that are produced. The dose is directly proportional to the tube current. As can be seen in the lower graph, using the MAS as a proxy for the dose allows us to assess relative doses as the size of the individual changes, and you can see that we can produce significant dose savings by tailoring the technique parameter for MAS to the size of the individual. Modern scanners are multi-detector scanners that became available initially in the mid-1990s. They significantly reduce the acquisition time and allow equal acquisition in X, Y, and Z directions. The detector configuration determines the beam width or aperture or collimation. It's the product of the number of data channels multiplied by the detector width for each data channel. As a rule, smaller beam apertures have a higher CTDI vol than larger beam apertures, as can be seen in this slide, and thus additional dose savings can be made by always using the largest possible aperture. Table movement through the scanner is either classified as table feed for helical acquisitions, being a continuous motion, or table increment for axial acquisitions, which is more of a step and shoot. The pitch is the ratio of the table feed per gantry rotation divided by the beam width. Patient dose is inversely related to the pitch. If the pitch is less than 1, there is overlap between scans and the dose will increase. A pitch greater than 1 has no overlap but may have gaps in the data, and though the dose decreases, there also is a loss of information where there's no scanning. The effective tube current time product, or MAS per pitch, is the product of the tube current, the exposure time per rotation divided by the pitch. The dose is directly proportional to the effective tube current. Lowering the MAS is the most direct way to lower the radiation dose. Lowering the MAS too much, however, can produce a lower quality image and result in a misdiagnosis or a repeat scan necessity. The exposure length is the length of the patient anatomy in the Z direction exposed to the X-ray beam, and the number of phases is the number of times the same anatomy is irradiated, such as for a brain perfusion, to produce an intensity concentration as a function of time curve. There are a number of enhanced dose reduction strategies possible. Most of them are based on an automatic exposure control assessment, where either the tube current is modulated based on patient size and attenuation, or the tube potential is adjusted based on the body size and the study type. In these cases, centering the patient in the gantry is vital for most AEC systems. Typically, the dose will increase for large patients and decrease for small patients. The lower part of the slide shows the longitudinal dose modulation from the beam current, and then longitudinal and axial modulation in the lower right. As I mentioned, it's important to ensure that the patient is centered in the gantry. We can see here the consequences. If the patient is below the table, they will appear to be smaller. If they're above the center of rotation, they will appear to be larger, and thus the AEC will incorrectly adjust unless they're appropriately centered. In addition, we can also use ECG-based tube current modulation for cardiac studies to limit the radiation to certain parts of the cardiac cycle. And we can use organ-based tube current modulation to spare radiosensitive organs such as the breast, as can be seen in this example. In this case, the dose is reduced to the anterior surface of the patient for the breast, but increased in the posterior to equalize the radiation throughout the patient to get adequate study quality. An additional and newly developing area is using iterative reconstruction algorithms in which information acquired during the scan is repeatedly passed through an algorithm that produces an image with less noise. Iterative reconstruction does improve image quality compared to filtered back projection and allows acquisition and reconstruction of diagnostic quality images at far lower doses. As can be seen in the three images at the bottom, the lower left is using a 100% dose of 160 mass, the center 1/10 of that dose at 16 mass, which is very noisy, and then after iterative reconstruction, that same 16 mass data produces a diagnostic quality study. There are a number of image quality parameters that are important: the image noise, or the variability in the image, which affects contrast to noise resolution, and spatial resolution is typically determined by the filter and scan parameters such as slice thickness. In addition, we need to occasionally assess artifact presence. Optimization of CT protocols remains an ongoing process. New scanner technology offers opportunities to reduce radiation dose through automated tube current modulation, automated tube potential selection, and iterative reconstruction. New scanner technology also offers new challenges to reduce radiation dose, since more complex exams and capability invite overuse and higher doses. In addition, dynamic studies such as we have seen for brain perfusion have significantly higher doses and need to be fully optimized. Thus, it's best to use a team approach of a radiologist, a physicist, and a technologist. The radiologist is responsible for ensuring that every study is thoughtful, appropriate, indicated for that particular patient. The technologists are responsible to ensure that protocols are adjusted to optimize parameters and verify proper scan technique factors are set, and medical physicists are responsible for improving image quality, providing guidance on appropriate pediatric techniques, and ensuring that patients are imaged using radiation as low as reasonably achievable, or ALARA. Some practical tips to consider are: first, to review the number of previous radiation studies to ensure that over-radiation in a cumulative sense is not occurring. Also, assess the reasons for the current study and perform only necessary CT exams, but also consider alternative imaging modalities such as MRI or ultrasound. Scan only the organ or anatomic region indicated, decrease the KVP on smaller sized patients, use MA modulation, use the appropriate field of view, use iterative methods to further reduce the dose in patients, and eliminate whenever possible multi-phase studies, and reduce the MAS in repeat studies such as shown in the lower right on this image, where verification of shunt placement is possible at a significantly reduced dose. So in conclusion, radiologists can successfully implement a system of continuous process improvement for CT radiation dose reduction by determining baseline dose levels for various CT study types at their institution, setting goals for dose reduction, modifying CT protocols, and implementing the changes incrementally and iteratively to minimize adverse effects. Thank you very much.